So a cleft lip results from failure of fusion of the maxillary and medial nasal processes, which comprise the primary palate. A cleft palate results from severe abnormalities. You have the failure of the fusion of the two lateral palatine processes, or failure of fusion of either of the processes with the nasal septum and or the median palatine process. So when a cleft palate occurs, what else can you often observe? A split uvula, yeah. It's important to know that cleft lip and cleft palate have two distinct etiologies, yet often occur together. It's even more important to know that both these conditions have a multifactorial inheritance. I had that exact question on my step one. Finally, we're going to talk about the embryology of the reproductive tracts. Now, every embryo starts out with two sets of ducts, the Müllerian ducts and the Wolffian ducts. Just to keep things interesting, these ducts each have a different name. Mullerian ducts are also called the paramesonephric duct, and the Wolffian ducts are also called the mesonephric ducts. Okay, so embryos all start out with both sets of ducts, but they each only end up with one. The default pathway in the absence of an extra chemical signal is for the embryo to differentiate along female lines. That means that the Wolffian ducts degenerate and the Mullerian ducts persist and develop into the female organs. Therefore, the Mullerian ducts turn into the female internal organs. So that would include the fallopian tubes, the uterus, the upper one-third of the vagina. You could imagine that in the condition called Mullerian agenesis, females would not have any of these organs, and so how do you think they would present? With primary amenorrhea and a blind ending vagina with no cervix or uterus on physical exam. Now in males, something happens to alter the course of this development. That thing is the SRY gene on the Y chromosome, which produces something called testes determining factor. Can you guess what this factor does? That's right, it promotes testes development. And once you have testes, you get two types of cells, the Sertoli and Leydig cells. We'll discuss these cells more later in the chapter, but for now, just know that Sertoli cells secrete Mullerian inhibitory factor. Again, this factor has a usefully descriptive name, so can you guess what it does? That's right, it suppresses development of the Mullerian ducts. At the same time, the Leydig cells secrete testosterone that promotes development of the Wolffian ducts into the male internal organs. In addition, testosterone gets converted into more potent form, dihydrotestosterone, abbreviated DHT, by the enzyme 5-alpha reductase. Now, what you do need to know is that DHT will give off the external male genitalia along with the prostate. Very important to know. DHT is needed for the development of both. Speaking of DHT, let me give you some general advice real quick. Make sure that for any abbreviation or acronym that you actually know what it stands for. I learned this the hard way during my exam when I realized serotonin's real name was 5-hydroxytryptamine, which was 5-HT. Of course, there are also specific things that can go wrong in males. Consider this pathway charting the events that are supposed to happen downstream of the SARI gene. So you have the Y chromosome with the SARI gene going to the SARI protein. This can give you the gonadal ridge, will give you the Leydig cells for testosterone and DHT. Also, you get the sex cords, which give you the Sertoli cells, which will make anti-Mullerian hormone and suppress the Mullerian duct structures. So if there's something wrong with the Sertoli cells, whether they're absent or they're not making Mullerian inhibitory factor, you'll get testes, but you'll have the female tracts that persist as well. However, the Leydig cells are still working and producing testosterone, so you will have male internal and external genitalia as well. On the other hand, if you take something like 5-alpha reductase, which is supposed to be right here, as it will be converting testosterone to DHT, if you have something go wrong with it, then you'll have testosterone and normal male internal structures, but know what? You won't have DHT for the development of male external structures. These individuals can be born and raised as females, but typically develop more masculine secondary sex characteristics at puberty. We'll talk about this later on in the chapter. So let's talk about uterine Mullerian duct or Mullerian duct anomalies. During embryology, the uterus may undergo one of many deformities. For example, over here in image A, we can see what's called a septate uterus, which results from the incomplete resorption of the septum. This is easily treated with septoplasty, which is basically surgery to fix the septum. Now, if we look at image B over here, we can see a bicornuate uterus, which is an incomplete fusion of the Mullerian ducts. Although surgery correctable, what process could this anomaly complicate? Pregnancy, exactly, as the embryo would essentially be growing in half of a normal uterus. Lastly, we have what you can see here on image C, which is known as the didelphys uterus, which is secondary to complete failure of fusion, or to cervices. So as we said earlier, the bicornuate uterus. What uterine anomaly is this? This is a bicornuate uterus. Here's a useful chart showing how the same embryological structures develop into the different male and female external genitalia under the influence of estrogen in the female versus testosterone in the male. Most of these aren't tested particularly often, but if there's one exception, it would have to be the urogenital folds, which you can see right here. So what's so different about it? While in females they form the labia minora, in males these come together and fuse to form the anatomical ventral shaft of the penis, which is the underside of it. It likes to be tested, it's very high yield, but this table in general, please do know it very well. Now, talking about congenital penile abnormalities. Failure of the urogenital folds to fuse results in the urethral opening occurring on the underside of the penis rather than the lip. So this condition is called hypospadias. These are fixed surgically because otherwise they're associated with a very high rate of UTIs. Meanwhile, you have epispadias, which is when the urethral opening in the dorsal side of the penis doesn't fuse, and therefore you have a faulty positioning of the genital tubercle during development. So finally, note that both the ovaries and the testes descend from their original position in the peritoneum. They have similar anchors, which is a fibrous band, known as the gubernaculum in males, and the ovarian ligament and round ligament of the uterus in the females. Now also in males, the outpouching of the peritoneal tissues persists as a tunica vaginalis. Remember what happens if the tunica vaginalis fails to fuse. Think back to GI. Exactly, you would get a hernia. Now would it be direct or indirect? It would be indirect, exactly. On the other hand, incomplete failure of the processus vaginalis results in just a small opening where only peritoneal fluid can leak through. Then you would get a hydrocele. In females, the evagination of the peritoneum is completely obliterated. On that note, we are done with reproductive embryology. I have a few questions lined up for you here for practice purposes. See you guys for anatomy. So which of the following is the adult male counterpart of the genital tubercle in the embryo? It would be B, the glans penis. So the genital tubercle is the glans penis in males and the glans clitoris in females. The bulbourethral glands in men are derived from the urogenital sinus. The prostate gland would be derived from also the urogenital sinus. The scrotum would be derived from the labial scrotal swelling, and the ventral shaft of the penis would be from the urogenital folds. Here's another question. A woman gives birth to twin girls via cesarean section. The obstetrician notes that although each twin was contained in her own amniotic sac, there was just one placenta. What kind of twinning is described in this case? It would be monozygotic twins that split after day 3, because you have a monochorionic diamniotic pregnancy. Conjoined twins occur in a monochorionic monoamniotic pregnancy. Dizygotic twins are completely separate zygotes, so they never fuse to begin with. And monozygotic twins that split before day 3 would be a dichorionic diamniotic pregnancy.